Good evening, everyone. My name is Ashley DePriest. I'm the president for the Southeast Chapter Society of Critical Care Medicine, and I'd like to welcome you to tonight's educational lecture. We have a few announcements to start off tonight's program, and then I will introduce our speaker. But first, we always like to begin our meetings by stating our mission and our vision. The chapter's mission is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Our vision is that all critically ill and injured persons in the Southeast region will receive care from a present, integrated team of dedicated, trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. The Southeast chapter covers the largest section of the United States in terms of geographical region. So we have many states, and we'd like to encourage you, if you're not already, to join our chapter. We have a QR code down at the bottom there. You can snap a picture. You can also visit sccmse.org/membership for more information on how to join our chapter. Tonight's lecture will feature Dr. Matt Siuba, and I will introduce him in just a few minutes. But we would also like to remind you that tonight's educational lecture will provide one contact hour of CE credit for physician, nursing, pharmacist, and dietitian. Please make sure you complete the evaluation. Clearly, that's a very long link there that you could copy and paste, take a picture, or you can use our CE code, the QR code at the link in the top right-hand corner of this slide. I'll give everyone just a few minutes to snap a picture of that. You do have 2 weeks to complete the CE survey after the talk. If for some reason you miss this link, you can always email us at communications@sccmse.org. And again, this evaluation must be completed by Tuesday, October 27th in order to get CE credit. Once again, there's a QR code in the top right-hand corner of this slide. You can snap a picture to link you to our evaluation, which can be completed during the lecture this evening or at a later time, but make sure you get that completed before October 27th in order to obtain CE credit. Just a reminder, you can always support the chapter by shopping Amazon Smile. If you go to smile.amazon.com and choose Southeast Chapter of the Society of Critical Care Medicine as your charity of choice, and every purchase you make, Amazon donates a portion of that purchase price to our local chapter. A special shout out here for the rest of our leadership team, especially Rita Gaid, our treasurer Ah Hyun Jun, and our secretary Marina Zorning. But a quick update, we do have upcoming elections coming up this year. So officer elections will be held at the end of December. Please be looking for an email. If you are a current member of the chapter, we'll be sending out an email here in the next few weeks to request applicants for our executive chapter leadership, as well as voting email coming out before the end of December. Also a reminder that this year's SESCCM Critical Care Congress will be held in February 2022 in San Juan, Puerto Rico. We hope you'll join us, and if you do plan on joining us, let us know. We'd love to meet you in person. We're happy that we'll all be together again in person this year from our virtual Congress last year, so really looking forward to catching up with everyone in San Juan in February. Once again, lots of membership benefits. You can sign up at sccmse.org/membership if you're interested in joining our chapter. A couple other activities we have coming up in the near future. Our student-led critical care live Twitter chat. We have one coming up in early November, so please be on the lookout. Follow us on Twitter at SESCCMSE and follow the hashtag SESCCMSEchat for more information on our Twitter Journal Club. And we also have a bite-sized lecture series coming up also in November, featuring a topic discussion on GI bleeds in the ICU. If you'd like more information, or if you're interested in presenting a bite-sized lecture or a Twitter Journal Club, you can always email us at communications@sccmse.org. We're also always looking for meeting topics and speakers, especially as we begin to plan for 2022. If you have any ideas for speakers or topics, you can always email our programming chair, Doug Smith, His email is there at the bottom, or you can also reach out to us at communications@sccmse.org. Follow us on Facebook and Twitter, especially Twitter. We're very active there. We'd love to have chats with you and talk about more critical care, and also continue tonight's discussion as well. So without further ado, I'm going to introduce tonight's speaker. Dr. Matt Siuba is an intensivist and assistant professor of medicine at the Cleveland Clinic, where he also serves as an associate program director for CCM Fellowship. His research interests include predicting response to treatment in ARDS and circulatory shock. He's a passionate mechanical ventilation educator and does so in person as well as on criticalcarenow.com. He writes about minimally invasive, maximally attentive critical care at zintensivist.com. And I know we also are all friends on Twitter as well, so I'm sure we'll be continuing the conversation after this. But please welcome me in joining Dr. Matt Siuba. I'm going to share my screen here with you. Switch it over. Perfect.
All right. Thanks so much, Ashley. Thanks to Ashley and Doug for coordinating this. I'm excited to be here. This is a topic that's near and dear to my heart. Anything really related to ventilation is, but especially this one in particular. Appreciate the introduction by Ashley. A couple of things I want to just sort of emphasize, since I think I haven't met a lot of you before, is the mechanical ventilation education is very important to me, and we do so, like Ashley mentioned, online and also in person. But in addition to that, I'm also now serving on the ATS guideline committee for the update in mechanical ventilation and ARDS for the next update. So this is something I read about a lot, I think about a lot, and I'm hoping to share some ideas with you, and hopefully that we'll have a nice discussion about it. So without any further delay, we'll move on. I have no financial conflicts of interest whatsoever, and certainly nothing related to this talk. And let me just make sure I can find my pointer so I can advance this. There we go. So the objectives today, first of all, if we're going to talk about driving pressure, we need to define what it actually is mathematically and physiologically. I promise there'll be very little math in this presentation. We'll describe the evidence for driving pressure as a prognostic variable, but then also explore some ideas about how it may be helpful to us as a therapeutic target or a therapeutic value. The definition and physiology obviously has to come first before we talk about anything else. A lot of us that take care of critically ill patients are familiar with the equation for compliance, which is the tidal volume over the delta pressure, which is in this case the driving pressure. If you flip this equation upside down, it becomes the equation for elastance, and you say, okay, why do we have two names for the same thing when you flip it upside down? Well, it's easier to conceptualize it one way or the other depending on how it's being used. In this case, compliance is kind of easy. How much pressure does it take to generate the tidal volume that we're talking about? So I have highlighted here the delta pressure, which is really going to be the driving pressure. When you're managing a patient on a mechanical ventilator, that means you have to obtain a plateau pressure and subtract that from the PEEP, and that value gives you the driving pressure. So that's a nice, simple, easy way to learn a lot about a patient with two numbers and one resulting value. Putting this all together, driving pressure gives us an idea of the relationship between tidal volume and compliance. Again, without getting into math too heavily here, you can see that by this equation, if you had a higher tidal volume for the same compliance, you'd expect the driving pressure to be higher. And if you had a lower compliance for the same tidal volume, you expect it to be higher. So you'd say, okay, well, why do I care about this? Why does this really matter? If I know compliance, driving pressure, they kind of sound like they're the same thing. I think here's the value of it. When we're talking about patients with acute respiratory distress syndrome, we're talking about lungs, everyone thinks about sort of lung stiffness. We're really talking about small lungs. So in this patient CT scan, this is probably even a little bit generous of a representation of what tidal volume is actually available to participate in gas exchange. In an ideal world, we're scaling the tidal volume down to the size that's available to us in the patient. And the things that we'll discuss later will show you that the amount of tidal volume available to participate in gas exchange and things that we normally pay attention to, like the PaO2 to FiO2 ratio, don't necessarily correspond with one another. So this provides some additional information. And if you think about it, I'm talking about the pressure that's required to generate each breath. So the driving pressure then is the cyclic opening and closing pressure or stretch that's applied to the lungs. and that's something that becomes important for a variety of reasons. First of all, if this is a concept you're not familiar with, how might I actually measure it? I'm going to put some caveats to the way that this should be measured, and the main reason for that is most of the data that's been generated has been from reanalysis of pre-existing clinical trials, and in those trials, plateau pressure measurements are done in a pretty deliberate way. The patient has to be passive during the pause, because if they're not passive during the measurement, then it's going to influence the values higher or lower depending on what sort of breath they're making at the time. Generally speaking, this patient should probably be in a controlled mode of ventilation. By controlled mode, I mean like a traditional volume control or pressure control, because again, this is how this data was obtained. And the plateau pause should be less than or equal to 0.5 seconds. This is probably shorter than the duration that you're using, and this will have an impact on the measurements, which I'll discuss in just a few slides. So if you're looking at the ventilator and you're looking at the pressure waveform, this would be a typical pressure waveform for a patient that's not making effort during volume control. But we're looking at the pressure waveform. So you see here I've represented the peak pressure and I've represented the PEEP. But I didn't mention peak pressure when I was talking about driving pressure, because that's not the value that I'm looking for. So you'll go to the ventilator and you press the inspiratory hold button, and then you'll get a waveform that looks something like this. By pressing the inspiratory hold button, you close the valve on the ventilator so that flow cannot enter or leave the circuit. The idea here is to eliminate flow from this equation so that the component of ventilation, or the component of the lung mechanics that represent the resistive load are removed, because really, again, we're talking about compliance. We're not talking about resistance. So at the end of this short pause is the plateau pressure, and that's something the ventilator will report off to you. The difference, again, between the plateau and the PEEP gives you the driving pressure. If you want to be a purist about it, probably the total PEEP should be the different, so if there's any intrinsic PEEP in the system, like if the patient has dynamic hyperinflation or the expiratory time is too short, the total PEEP might be higher. But again, we're using information that's derived from derived retrospectively, so everything probably in those measurements didn't account for auto PEEP. And then finally, I just want to emphasize again that the pause in this case should be less than or equal to half a second, which is really short compared to how most people measure plateau. This study will shows physiologic differences and how driving pressure values are obtained depending if you do a long pause of 2 seconds or a shorter pause. On the x-axis here, we see how long the duration of the pause is versus how it affects the driving pressure. You see a longer pressure gives you, a longer pause gives you a lower pressure, generally speaking, because you get some stress relaxation, and then if there's any sort of leak in the vent circuit, you'll get extra air leaking out at that point. So that's just something to pay attention to. This is important because in this study, patients would be reclassified as having a safe or non-safe driving pressure depending on how long you hold the pause for, and whether or not you account for total PEEP, not just the set PEEP on the ventilator. So that will reclassify patients from going from 5% having a safe driving pressure to up to 43% in this study having a safe driving pressure. The QR code here on the slide I want to point out is the link to this study. That's how I do my references. So throughout this entire presentation, everything that you see that's coming from the literature will have a QR code attached to it. So then the next question is, if I'm going to make changes on the vent, so now I know how to measure this value. If I'm going to make changes on the ventilator, let's say to the tidal volume or the PEEP, how long after the vent check or the vent change can I check the value again? Do I have to wait an hour, 2 hours, a day? There's a really nice physiologic study here that's referenced that used a driving pressure strategy to titrate PEEP, so trying to get to the lowest driving pressure. And basically what you can see here is between 1 and 5 minutes, the values don't really change to what you'll see at 30 minutes, and the same was true at an hour. So whatever you see in that first 5 minutes of playing with the ventilator, it's probably not going to change much. I do want to add an important caveat that the gas exchange changes that result from your changes, let's say the oxygenation change or the CO2 change, those you will not see this quickly necessarily. It could take an hour, it could take longer than an hour. But just to see how the numerical value of driving pressure changes, it only takes a few minutes. The first thing and the strongest data for this value is for the sake of prognosis. The paper that first got me interested in this, and probably is the most cited paper on this study, is the Amato et al. Paper from NEJM, which again is a secondary analysis of prior completed clinical trials in ARDS. To start off, driving pressure in this study predicted survival as well as the Apache score or SAP score, which again are severity of illness scores, and outperformed P to F ratio, which is important. When you put driving pressure in a multivariable model and you count for things like their underlying severity of illness, their age, their P to F ratio at entry, or their arterial pH at entry, you see this clear relationship where as the driving pressure rises, the mortality risk increases significantly. Roughly around 15 is where you see this inflection going from you know, a reduced or neutral risk of death to an increased risk of death. So that number will recur over and over again. So just think 15. Less than 15 is something that would be associated with better outcomes. There's different cutoffs used in different studies, 12, 13, 14, but 15 or less is a pretty consistent value. So this study did something called a statistical technique called a mediation analysis. So some people have referred to this study as the mediation analysis on this topic. So I will talk very briefly about what that really means, just for the sake of understanding why this value is useful. So here's a little diagram that shows a relationship between the values. So the studies that were included in this Amato paper were testing assignment of patients to either different tidal volume strategies or different PEEP strategies. And then they were assessing, of course, mortality, which is a very common outcome in critical care. What a mediation analysis does is says, if there is another variable that is affected by, let's say, tidal volume or PEEP assignment, but it is not actually something we're directly targeting, if it's shown to have a large relationship between the outcome and between the treatment assignment and the outcome, that says that that value may be useful. So what I'm really trying to say is, if they can show that driving pressure is really important in an equation, in a model where you're looking at how patients were assigned to different treatment groups, then that's something that says this value may be independently useful. And to describe that a little bit better, in this study, they found that 75% of the benefits due to treatment group in the tidal volume trials was associated with driving pressure. So if your treatment group, let's say you were in a low tidal volume group versus a high tidal volume group, and the driving pressure was lower, that was likely to be mostly responsible for the benefit. And we'll describe that in a little bit more detail with some subsequent studies. 45% of the benefit of PEEP trial assignment into different groups was also mediated by driving pressure. So basically, even though if driving pressure improves based on the treatment group you're assigned to, that was something that was associated with improved outcomes. And again, this is, you know, at least half of the responsibility in the PEEP trials and most of the responsibility in the tidal volume trials. And like I said, we'll discuss that in a little bit more detail. What's really interesting is in the same study, they did a resampling of patients that had similar values for PEEP and different values for driving pressure, and saw how it affected mortality. So if you had a group of patients that had the same set level of PEEP, let's say in panel A here, but as the PEEP was increased, their driving pressure increased. You can see in the bottom part of that panel that this suggested that mortality would increase if that driving pressure was rising as your PEEP was changing. Conversely, if your PEEP sorry, let me restate that. That was not correct. So for the same level of PEEP across different groups, as the driving pressure rose, that suggested worsening outcomes in terms of mortality. And the second set, where we matched the driving pressure, as you increase PEEP, we really saw no difference in mortality. And then finally, really interestingly, as if taking patients who had the same plateau pressure but different levels of PEEP showed as the driving pressure decreased, you're likely to have a decrease in mortality. And again, this is retrospective, observational, but very interesting. A systematic review meta-analysis looked at similar questions with different set of studies and showed that this relationship of high driving pressure and mortality was also seen. So a lot of those earlier studies included patients that had high tidal volumes, which we know is not something that we would ever do in the year of our Lord 2021, but you know, sometimes you see it. So what happens when patients are enrolled in trials where low tidal volume strategies were the standard? So in this case, we're talking about a study that reanalyzed Accurasis, which was a neuromuscular blockade study, and Siuba, which was a prone positioning study. So all these patients were assigned to low tidal volume. And then their treatment group allocation was based on whether or not they received the intervention. So in this case, driving pressure still holds as a differentiator of patients who are more likely to die if their driving pressure is elevated. In this case, the value of 13 was used as the best cutoff. However, in this study, other values still had useful values to predict mortality. So in this case, a higher plateau pressure, which we know is bad, also predicted mortality. Higher mechanical power, which is a complex equation that I don't really want to talk about today. And then compliance maybe not has a relationship. Certainly a lower compliance would be associated with worse outcomes. But you see all these values are kind of related, so it's a little hard to tangle out what is driving the actual change. What about long-term outcomes? Is there anything that driving pressure can tell us about that? Well, if we take patients that were enrolled in in ART, I don't want to say ART trial because it's a little redundant. Patients who were enrolled in ART and you looked at their long-term outcomes in terms of their lung function, what's really interesting is there's a reasonably strong correlation between driving pressure at 24 hours post-enrollment and the forced vital capacity at 1 month and 6 months after ARDS. So whatever is happening initially actually leads to perhaps decreased lung function going forward. Again, that could be related to the severity of underlying disease, but it's interesting that it holds as a prognostic indicator in this setting. Because we're all still inundated with COVID, unfortunately, we can also talk about how driving pressure, what value driving pressure has in COVID-19. And just to be clear, because this is often an area of controversy, COVID-19 ARDS, I think, is just ARDS. You can disagree with me, but I think ARDS is ARDS. So what did we learn from driving pressure with COVID? So with a driving pressure, going from a driving pressure of 10 to 14, your mortality risk, your odds of mortality increased by 46%, which you see in panel B. But similarly, compliance was also predictive of increased mortality, you see as your compliance goes lower. So again, these values are related. So maybe it doesn't add very much over compliance. But again, kind of an easier value to conceptualize. Tidal volume, interestingly, in this study, did not have an association with mortality, a detectable association with mortality. But interestingly, the mean tidal volume per ideal body weight in the study was almost 8, with a range going up to 8.8. So a little higher tidal volumes than some of us would like to see, but similarly, you can see there was no detectable relationship between tidal volume and mortality. Another really interesting study, which I think will add some fuel to the fire of when should we intubate COVID patients in that debate, is the amount of time a patient had respiratory distress, which really was just defined by tachypnea, because this is a retrospective analysis, or the number of hours with a P to F ratio less than 100 before intubation. So these y-axis values are before intubation. You can see there's a clear correlation between hours with worsening values of both of those and the initial driving pressure. And unfortunately, this also had a relationship with mortality, where patients with a higher driving pressure in this study, based on these findings, had about twice as high a risk of mortality compared to patients with lower driving pressure values. Now we can ask, what are some potential values of driving pressure in patients that don't have ARDS? Does this mean anything in these patients? Because we say, okay, their parenchyma is probably pretty normal. We maybe don't have to worry as much about, over distension of healthy areas, or, trying to open areas that are not open. So what can we learn about this? Well, realistically, in this analysis, there was really not a good relationship between not a detectable relationship between driving pressure and mortality in non-ARDS patients. So we can say, all right, well, maybe this is something we should only pay attention to in ARDS patients. However, a recent study showed that a higher driving pressure, and then here's the groupings, as your driving pressure increases, your risk of developing ARDS actually increases. And this was from a prospective observational analysis. But it's very interesting that patients without ARDS with a higher driving pressure are more susceptible to developing ARDS. And you can see as you get to above a driving pressure of 15, adjusted odds ratio is around 7 for the development of ARDS within the first month. Next, we can't just always think about the lungs. Obviously, if the lungs were all that mattered, we can just make people's gas exchange better and then they would survive. But obviously, there's a lot of downstream and extra pulmonary implications of ARDS, and we should consider whether driving pressure has a role here. The first thing is thinking about the people's ventricle, which is the right ventricle, which is really, the more interesting ventricle. In this analysis, again, retrospective observational, 2.26 times risk of acute cor pulmonale if your driving pressure was over 15. And they actually, in this particular study, they actually put driving pressure into as one of the main risk factors for development of acute cor pulmonale. But for the risk score, they actually used a cutoff of 18. But you can see that that magic number of 15 still holds here as providing useful information. So you might think, okay, if I have higher driving pressures, higher stretch, maybe I'm not only causing issues to the right ventricle, but maybe there's going to be some back pressure, some downstream effects to the kidney, for instance. In this analysis, which is cited inside the kidney there, driving pressure was actually not associated with the risk of developing acute kidney injury, but the compliance was and the set PEEP was. So those are things that we still need to keep in mind as we're making adjustments to the ventilator. As we know, acute kidney injury is a very common second organ to go down in a patient with ARDS. Now, the most interesting but most nebulous part of this talk is, what is the potential therapeutic value? What can we think, what can we do with these retrospective analyses, and how can we take this to the bedside, or can we take this to the bedside? So our rationale for doing this is we have a lot of signal that says this value, when it's abnormal, let's say over 15 or over 13 in different analyses, this number says that the outcome is going to be bad. So maybe it's a value that I should modify. We certainly don't have any prospective trials that support that. But my counter question to you is, beyond setting a low tidal volume and using PEEP tables, what kind of targets are we using to determine if we're making progress with the ventilator? The thing that we most pay attention to is oxygenation. We can make oxygenation better in ways that are not necessarily helpful for the patient. So in ARMA, back in the early 2001, the patients assigned to the higher tidal volume group had a higher oxygenation. We know that's not necessarily a good thing because the mortality was much higher in that group. PEEP can certainly improve oxygenation. We have never shown that a PEEP strategy that improves oxygenation was clearly associated with improved outcomes. We know pulmonary vasodilators make oxygenation better, but that's not something that's ever in any way, shape, or form been shown to improve any, at least mortality. Really just makes the oxygenation number look better. And then finally, prone position ventilation. Obviously, I love prone position ventilation. I think it's something that anybody that qualifies should get it. But the benefit from it, the benefit that comes from prone positioning is not necessarily predicted by better oxygenation. And that's what's discussed in the scientific letter that's listed at the QR code there. So better oxygenation doesn't actually necessarily mean that your lung protection is better. And better oxygenation doesn't actually mean that your mortality is going to improve. Interestingly, changes in driving pressure have better prognostic value in patients enrolled in clinical in these two PEEP trials, alveoli and express. Change in driving pressure was better associated with an improved outcome than was change in P to F ratio. So maybe we need to pay attention to how much we're stretching the lungs or how well we're sizing the lung, the tidal volume to the amount of lung that's available. I return to this resampling analysis from the Amato paper just to kind of re-demonstrate this idea that if the driving pressure is being made better by the things I'm doing, maybe I'm going to have better outcomes. To think about this idea in a little bit more detail, it might help to think about how to apply it to a patient case. And using sort of this kind of idea, we described basically, a couple of cases at this link. If you want to read more about it, it's a little bit too much to discuss today, but it's basically a practical example of how this might happen, how you might use driving pressure to titrate PEEP. So let's return back to the CT scan. We have the tidal volume per the compliance that's available, which is going to be represented by our driving pressure. When I increase the PEEP, I'm hoping that maybe some of this will recruit. It may or may not. We don't really know if that's something that's going to be beneficial. But what if, instead of thinking about PEEP as a driving pressure as a target to titrate PEEP, we think about it for tidal volume. So this is, again, how we hope that we're scaling the tidal volume to the available lung in a patient with ARDS. However, sometimes we may be providing a tidal volume that would actually extend much further than what we're expecting.
Doesn't work.
With that in mind, yeah, somebody's unmuted. Oh, okay. Okay, good. All right. So when we're applying some, let's say 6 or 8 cc's per kilo, sometimes we might be trying to apply tidal volume into this space, which obviously won't happen, and it'll just over-distend the apical portions of the lung, which are more compliant and well aerated. So it'd be kind of nice to use this as a target to determine what's an appropriate tidal volume. To show it a little bit more elegantly, panel A and panel B, for the same tidal volume but very different compliance, you can see you'd be much more likely to cause tidal overstretch of the apical parts of the lungs. Whereas if you drop that, for the same compliance, if you drop the tidal volume, you can improve the driving pressure and hopefully improve overstretch. One of my favorite papers in the last year that came out was this paper by Costa and Gallagher and colleagues that shows that the benefit, in the original tidal volume trial, so this is going back, late 90s, early 2000s, the benefit of low tidal volume ventilation really varied depending on how elastic the lungs were, or how poorly, how well or poorly compliant the lungs were. So lower compliant lungs benefited more from a higher, lower compliant lungs benefited more from lower tidal volume strategy than patients with normal or lower normal compliance. You can see that when you take the elastance, and in this study they used elastance normalized to the size of the patient, so it includes their weight. You can see the higher tidal volume strategy really increases risk of death when the lungs are poorly compliant, or you're overstretching. You're probably overscaling the tidal volume for how much lung you have to deliver it to. So in this analysis, they showed that lowering tidal volume effect on mortality and ARDS depends on the elastance, which again is just compliance flipped upside down. It communicates the same information. Low tidal volume ventilation, the benefit of it did actually not vary depending on how bad the P to F ratio was. And another important conclusion from this study was a 6 ml per kg tidal volume, which we think is great for everybody, may actually not be protective if your driving pressure is still at 15 or above. And this I think illustration shows how that might make sense. These two patients could have an identical P to F ratio, but obviously the amount of lung that is not consolidated or atelectatic is drastically different. So you could say the patient on the left panel probably needs a lower tidal volume than the patient on the right panel. And we don't do CT scans on everyone with ARDS, so that's something you have to really think about, paying attention to how the driving pressure is changing when you're assigning tidal volumes to your patients. For more on that paper, with some more discussion, I did a little write-up about it for our site, Critical Care Now. It's at that QR code in the middle of the screen. So obviously, there must be limitations to this because this is not something that's recommended. It's not something that's widely being applied at the bedside. As I already alluded to, there's no prospective randomized controlled trial data that uses driving pressure as a target. But let's see what is out there and what we can learn from it. So most recently, the REST trial came out, which was a trial that tried to target very, very low tidal volumes, under 6, down as far as 4, facilitated by the use of extracorporeal CO2 removal, which if you're not familiar with it, it's kind of like ECMO without the oxygenation support. It just allows you to provide sweep for CO2 clearance. The initial driving pressure in patients in this study, about half patients in the intervention group, which is on the left, and the control group on the right, had a driving pressure that was acceptable. So that's something important to consider when you see how things change. They didn't show, in some of their secondary analyses, they did not show that a benefit to this ultra low tidal volume strategy plus ECOR was beneficial based on your differential driving pressure. You say, oh, okay, well, that's not great. Here too, you can see the driving pressure days across days of randomization. The ECOR group had a lower driving pressure several days. The biggest differences were days 2 through 4, but still, again, no benefit in terms of mortality. They had to use more neuromuscular blockade to get people to tolerate the lower tidal volume. So, okay, maybe that's not panning out the way we'd like it to. And that's just showing the same information numerically, but you can see significant differences occurred on days 2 through 5, but not beyond that. So this, I think, at best is inconclusive results for a driving pressure strategy. But remember that lowering tidal volume, the benefit of that may depend on elastance. And because we didn't assign, treatment assignment wasn't done by that, we don't know if that strategy would be helpful or not. I will say, you know, it's significantly more intervention to try to lower tidal volume by adding, you know, another large invasive machine. So what other studies are out there that we can learn from? So we'll return to ART trial, which was the low PEEP table compared to an intervention group that received pretty aggressive recruitment maneuvers plus PEEP titrated to best compliance. Say, okay, PEEP titrated to best compliance kind of sounds like a driving pressure strategy. And here, lung recruitment, the intervention group actually had a higher mortality. Kind of concerning. And you can see here the intervention group on day 1, 3, and 7 seem to have a lower driving pressure every time. So what's going on here? Well, it's a little hard to disentangle the driving pressure strategy or the optimal compliance PEEP strategy from the very aggressive recruitment maneuvers. You can see how high they went with the airway pressures and for at least minutes at a time. So that may explain some of the worst outcomes in the intervention group in this study. Fernando Zampieri did a secondary analysis of this study, looking at patients in different clusters derived by machine learning. And interestingly, across all clusters, the potential benefit of the intervention group was much higher, or let's say went from being likely harmful to likely helpful if the driving pressure was centered around 20. So you can see it probably, if you assign, we may find different results if you assign patients to treatments based on their baseline driving pressure or the baseline elastance. So with that all said, what are we supposed to do with this information? So we know that driving pressure can be manipulated at bedside. We've talked about ways that we can do that. Changing PEEP will change your driving pressure. Changing your tidal volume will change your driving pressure. Prone positioning, not immediately, but probably on a delayed fashion will change driving pressure. Is it the right target? That's really unclear. And that's something that we're going to need more information to tell us. So in closing, I want to mention that driving pressure is an important variable that has clear prognostic indications. Future investigations will have to inform us about whether it's a good intervention target or not. But I think what we can say with confidence is it's a good safety measure. So we should be paying attention to it as we're paying attention to our tidal volume, our plateau, and other values. There's 3 or 4 trials in process now that will answer this question in one way or another, and I look forward to those results. Thank you so much for tuning in today. I appreciate you taking the time to be here, and I'm happy to answer any questions.
Great, thank you so much. We do have a few questions coming in here. Let's see. First one is from Marco Balin. I hope I said your name correctly. He says, although many seem to cite a target driving pressure less than 15, the studies appear to show graphs with mortality being lower the lower the driving pressure, rather than plateauing below 15. Might this suggest the lower the driving pressure, the more the benefit?
Yeah, I think there's enough signal to say that that's probably the case. I think 15 is a comfortable number because it comes up so frequently in these studies as a value that's important. Even that last paper talking about elastance, they didn't they didn't subselect 15 as a number that was important, but that's where it landed again. So I think 15 is like a hard cutoff. It seems like lower is better. There may be other consequences for that, hypercapnia, maybe some de-recruitment. So it's a little hard to say, but that's where I think, you know, prospective trials will be helpful to try to answer that question.
Sure, great. Let's see, next question from Doug Smith. Are there any ventilators out there that will show you driving pressure, or is there always a little bit of bedside math involved?
That's a good question. There may be, so in fairness, I think I only have exposure to 3 or 4 vent manufacturers. I don't have any Hamiltons. I don't have any Dragers. And generally speaking, I'd say probably not, unless you're having something, unless you have the vent set in a mode where you're having a plateau pause added to every breath, and then you'll at least see the plateau displayed continuously, like the McKay servos have that function. But if you know, it would be very easy then, since you have the PEEP and you have the plateau being displayed to show a driving pressure, but I don't think any of my vents do it.
Great. Yeah, it's kind of like with our calories. I know there's a few vents out there that will show your calories automatically. We love those, not having to do all the math.
Yeah.
Let's see. And so just a reminder for our audience as well, you can put questions in the question box or in the chat box if you have them. It looks like we have a couple more at least here. Can you give your opinion on checking driving pressure in patients triggering mandatory breaths? This has even been shown to be possible in pressure support modes. In fact, it seems to be possible that a driving pressure could be in the dangerous range, even if peak pressure is less than 15.
Yeah, that's a really good question. Yeah, this has been described. I thought about including it, but then for the sake of space, I did not. You absolutely could do this. I think the challenge is just determining. So if you give a pause on a patient that's actively inspiring or expiring at the time of the pause, it's going to cause a large deflection upwards or downwards in the value, and I think that makes it harder to interpret. If you can get it in a reasonably steady state, I don't see why you couldn't. The other thing that I didn't really talk about, obviously, is the value that this value is a surrogate. The value we'd really want to know is like the transpulmonary driving pressure, like what's actually happening at the alveolar level. And when we're looking at driving pressure, we're really incorporating, you know, chest wall mechanics as well. So we're talking about, you know, driving pressure of the respiratory system, where we really like driving pressure at the transpulmonary level. So yeah, I mean, it still could be injurious transpulmonary pressure if you have very vigorous efforts, let's say, for instance, and that would be something you wouldn't necessarily detect by looking at like the peak pressure, and then other maneuvers like occlusion pressures or things like that might be helpful. So I wouldn't say it's impossible. I'd say it's a little bit more challenging. And then you have other modes like adaptive modes or servo modes, things like proportional assist ventilation. Since you have a tidal volume and a dynamic compliance that's being reported out to you every time, you can actually take those values and then, you know, derive the driving pressure from that. And even in PAV, the driving pressure of 15 seems to be another threshold that you'd be worried about. But similarly, you know, if your compliance is under 30, that would be similarly worrisome. So there are spontaneous modes or patients that are making efforts, but I think you just have to be careful about how you measure it. If it's a short pause without a lot of effort during the pause, it's probably still valid. But again, remember, these are all surrogates for transpulmonary, you know, surrogates for things that we'd really like to know, which we don't have at the bedside easily unless you put balloons in people all the time.
Sure. Let's see. And this is kind of related, I believe. How low would you go on tidal volume in order to lower the driving pressure? 4, lower, maybe?
Yeah, it depends on what the patient will give you. My experience is I can't get, I have not gotten below 4 without, you know, because we don't routinely use extracorporeal CO2 removal. I haven't gotten below 4 without having issues with you know, respiratory acidosis. Because, you know, the lower you go, you're getting close to just ventilating the dead space. So I have gone as low as 4, but the caveat to that is like it has to be really well justified because then that almost similar to the rest trial results, it almost obligates deep sedation and paralysis, which I try not to do unless I really need to. But if the elastance or rather the driving pressure is still really poor at like 5, then I try to go down. I'll see what they will give me in terms of the gas exchange, if the gas exchange is reasonable. Everyone's target for permissive hypercapnia is different. Some people say none. Some people say, you know, different values under 7.3. For me, I generally will go down to 7.20 as long as I'm not seeing issues with right ventricular dysfunction or other changes.
Mm-hmm. Got it. Let's see, we've got several more questions coming in, and I think as long as you're good, we have time still.
Yeah, absolutely.
Let's see. let's see. Okay, so a lot of BiPAP we're using these days. Understanding how most studies define driving pressure, I realize this may be a stretch, but any utility in using driving pressure off a BiPAP?
Yeah, I would be cautious about that because by definition, you have a spontaneously breathing patient, probably with a decent amount of vigorous inspiration, excuse me. So I think in that instance, what you'd really want to know is the transpulmonary driving pressure, which again, you'd need like esophageal manometry to define. I think it's reasonable to be careful about how you set the inspiratory pressure on a patient with ARDS. The bigger question or the bigger issue, I think, is whether we should put patients with ARDS on non-invasive positive pressure, which could be a lecture in and of itself. The recovery RS data was like, maybe that's something. I will say that's probably made me moderate my feelings about it a little bit. I used to be kind of firmly no, based on the sort of observational outcome data that's available. So I would say I would be careful with using it on a patient on non-invasive. I just think you're not probably getting the value that you really want to know, which would be the transpulmonary driving pressure. And I can't imagine a world where we put everybody that has ARDS on non-invasive positive pressure with an esophageal balloon. That seems probably not practical nor comfortable.
Let's see. If we cut down PEEP with the aim to reduce driving pressure while ensuring oxygenation is still good when we do that, will the patient outcome improve?
Unclear. Really hard to say. I wish I had the answer to that. I will say practically, just from an experience standpoint, if I'm going up, kind of like I showed in that panel from the Amato paper with the PEEP resampling, I think if you're going up and your driving pressure is staying the same, then I think, or going down and your driving pressure is the same, you really have to look at other variables and say, what's happening. I think, obviously I love driving pressure because I'm here talking about it, but it's just one variable. And I think you have to take into account what's happening with the rest of the patient, what's happening in the right ventricle, what's happening in the hemodynamics. And those are the things that come into mind. So I think if I'm the counter to that, or I want to kind of flip that question on its head, is to say if I'm going up and the driving pressure staying the same and I'm not seeing any benefits, I probably start to come down actually a little bit. But I'm not generally speaking in a big hurry to get the PEEP low in a patient with ARDS, as long as there's safety parameters are being met and gas exchange is reasonable.
Got it. So kind of along those same lines, someone here is asking, is it better to reduce the tidal volume or reduce PEEP in order to reduce the driving pressure?
Yeah, that's a question that's not well answered, but I think the observational data suggests that the tidal volume, the benefit to do between the Amato paper and the Gallagher paper that I referenced, it suggests that probably the tidal volume is a stronger thing to target if your driving pressure is abnormal. But we've kind of been doing some version of this for a long time, because if you've been doing ARDSnet, you say, okay, the plateau is elevated even though I followed everything, so I'm going to drop the tidal volume. It probably makes more sense, I think, to do that because we're trying to, again, scale the tidal volume to the lung size that's available. But again, this question's not really been answered in a way that I think I can give a satisfying answer to, but I'm starting to get the feeling that maybe tidal volume is the thing we should think about first. And then once you have the tidal volume scaled appropriately, then you can start saying, okay, I'm going to try to see if there's anything recruitable, by changing my PEEP strategy or even making a decrement in my PEEP if I may be over-distending some healthy areas.
Let's see, pneumothorax or subcutaneous emphysema, how might these affect the accuracy in measuring driving pressure?
Yeah, I think there'd have to be a pretty big leak for it to cause an impact. Like you probably have to have a BPF, like a large BPF, bronchopleural fistula. But to be honest with you, I don't think I know that answer precisely. But I don't think, if you have a pneumothorax that's being treated and you don't have a huge air leak, you could probably trust the value. Pneumomediastinum, as long as it's not rapidly expanding, probably shouldn't have any impact on it. But I think a large bronchopleural fistula will probably falsely lower the number, or a pneumothorax with a large air leak potentially, but I wouldn't say that with confidence.
Got lots of questions coming in. I know we have a few minutes, so I'm going to keep going here. Are there any studies currently going on that relates driving pressure and mechanical power, or how may we relate those two?
Yeah, that was another, that's a great question. That was another study that, there's another study in blue, I think from Ewan Gallagher's group again in the last year, that compared different, different parameters of power and ventilation. And the confusing thing about the power calculation, and maybe people smarter than me understand it, is they used peak pressure, which again doesn't really reflect the question that we want to know. But in this study that I'm referencing, driving pressure was, they looked at the different components of mechanical power, and driving pressure was, they had the strongest association with the outcomes. And the next thing that came that was useful, the next variable that was useful was the respiratory rate. But it was, it had, I think, a quarter of the power that a quarter of the impact that the driving pressure had. So I think driving pressure is still reasonable surrogate for mechanical power, and at least in what we want mechanical power to answer for us, like as what I'm doing injurious or not. The catch then is, though, if I'm lowering driving pressure, I'm going to raise the respiratory rate, probably, if I'm dropping my tidal volume. But again, the driving pressure seems to be the more powerful variable between those two. So I think driving pressure would still take precedence. And again, I think the thing I really like about this value is it's just so easy, and I don't have to get a calculator out to do it.
Yeah. Always good to not have to pull out the calculator. Let's see. I have seen a few COVID patients whose driving pressure dropped significantly when they were placed from 30 to 45 degrees upright to supine position. What could be the explanation for this phenomenon?
So sorry, going from upright to supine?
Looks like, yes. Let's see. They were
Okay.
placed from 30 to 45 degree upright to supine position. Is how it's
Okay.
worded here.
So, I mean, there's a decent amount of physiologic data just in general for patients with ARDS, that if you have a patient, especially if they're obese, and you go from upright position to a flat position, you lose a significant amount of your functional residual capacity. It could be like, a liter and a half of their lung volume. So I think that would explain that. Hopefully I understood the question.
Yeah, that was kind of my impression too, and just thinking of someone with a larger belly, for sure came to mind. Have you found
Yeah.
it difficult to routinely obtain plateau pressures on your patients during COVID due to low frequency of docs and RTs going into rooms? Does your institution have a practice to obtain plateau pressure and driving pressure on a regular systematic basis?
Yeah, for the most part. So driving pressure is something that I think a large minority of us are using just pragmatically, but it's not something that's being necessarily routinely collected in a way that's being saved. So it's something more like when I go and play with the dials on the ventilator kind of a situation, which is frequently. A couple of things. If you have the ability, if the patient is passive enough that you can put a plateau pause into your inspiration, it could be short. Experientially, a 0.2 to 0.3 second plateau pause is probably enough to get close enough to the plateau pressure. And again, you could see that value continuously. So if I have a passive patient, my strategy is to put that plateau pause in, and then I can view the plateau and the set PEEP from the doorway if it's a COVID patient. So then I don't have to go in the room every time. And then I just have to do, basic math. But the neat thing that we've done at our main campus is we have the again, I have no conflict of interest with any ventilator company. We have the servo used, and we can disconnect the screen from the ventilator, and we got these really long cords. So the ventilator, the machinery of the ventilator sits in the room, and we have these tall poles that we have to put the screen on that sits outside the room. So we can do a lot more vent manipulation and vent checks that way. And that has drastically improved our ability to, make changes. And, I think anecdotally, I will say it makes it easier to not just say, okay, just go up on the sedation, which I think a lot of people would like to do, is say, okay, let me see if I can make adjustments to the ventilator from here, since I don't have to go in the room as frequently. So I think those are the two ways that I try to get around that.
Yeah. Could you use stress index in conjunction with driving pressure to find the optimal PEEP and tidal volume?
I think so. I think they reflect similar information, but obviously you're learning what's happening with sort of tidal stretch there. I think they're very complementary. I don't have a strong preference against. I use stress index sometimes Just bear in mind, it has to be passive patient who's in a volume control of the square waveform, if you want, with no rise time. Because there's a lot of time when they'll put a little rise time in, and then so normally the inspiration should go, begin in a completely upright fashion, but sometimes people put a rise in the breath, and so it starts a little slower. So you have to have no rise time, a square waveform, square flow waveform, and then you can measure that. You probably should use the vents calculation, the mode of calculation to do it rather than just the screen, because especially like, for example, the servo ventilators, they auto scale the scalers. So they change the way that the scalers look, and it makes it hard to tell how actually straight or not straight it is. But usually if you do an inspiratory pause and an expiratory pause, and you go to like the third screen, it'll show you the stress index. So I think it's helpful. It provides complementary information. Has it made driving pressure more or less valuable? I'm not sure. I think they're both useful.
Got it. You may have already answered this. Do you prefer checking the driving pressure by doing manual inspiratory hold or putting a set pause? I feel manual holds are generally longer than 0.5 seconds.
Yeah, they are, but they probably shouldn't be, because I mean, again, all the ARDS-net trials used the pause. They sort of mandated a pause of less than 0.5 seconds. So I try to be really, really brief with it. If you have a patient that's passive enough, you can put the pause in, or if they're paralyzed, obviously you can put the pause in, and then that makes it easy, and you don't have to go and keep checking it. But if you don't have that, then it's reasonable to just do a short pause. And again, the other nice thing about the short pause is it's less likely to, in my experience anyway, it's less likely to be influenced by patient effort unless they're making really vigorous effort at the end of the breath. But if you put a plateau pause on a patient that's not passive, it can be very uncomfortable because you're essentially locking out their effort, inspiratory or expiratory, during that pause.
Great. And it looks like one more question, then I'll have one last question to end us. We know respiratory rate is the highest multiplier in mechanical power. If driving pressure is high, will higher respiratory rate cause more injury or worsen outcome, since we usually increase respiratory rate to clear the CO2 to maintain low tidal volume?
Yeah, I worried about that a little bit more. I think it's a great question. I worried about that a little bit more before that most recent paper I was alluding to that said, driving pressure is probably 4 times more, had a magnitude of 4 higher impact on the outcomes in terms of relationship to mechanical power. So yeah, it's something I think about, but it's really hard to get around it. And again, we don't have anything prospective to say whether that, it's hard to do based on all of our other. It's hard to have a low respiratory rate in light of all the other goals that we have with ARDS. So I still, based on the available data, I still would value the driving pressure more. I'm not sure how much, does going from a respiratory rate of 24 to 30 make a big difference if the driving pressure got better in that way? Probably not, but it's, this is conjecture.
Sure. So last question, and as a dietitian, I always have to get a nutrition question in here. So do you think, I know we have a little bit of data, maybe a little bit of old data that shows the effects that muscle and diaphragm muscle specifically have on breathing, of course. So would knowing the nutritional status of a patient, whether they're coming in super malnourished or they develop malnutrition while they're in the ICU, does that help you in making a decision or change the way you approach mechanical ventilation in patients?
Yeah, I think specific to driving pressure, probably not, but in general, I would say maybe. I think if I have a patient who, let's say, I think they have, one of the newer interesting concepts in mechanical ventilation is not just lung protection, but diaphragm protection, which I think is super interesting, because over-supporting a patient is bad because they'll have diaphragm atrophy, and under-supporting them, they'll have sort of pathological hypertrophy and maybe develop diaphragm dysfunction that way. So probably the best thing there would be to make sure that the work of breathing is matched by the support from the ventilator. And unfortunately, a lot of the modes that we do don't do that. So if you have a patient in volume control who has high respiratory effort, they actually are going to, they're going to eat up all the flow and they'll have less support. PRVC, obviously, worst possible thing if you're trying to make vigorous efforts. So modes that are in the servo mode category, not to be confused with the servo vent. Modes like proportional assist ventilation or neurally adjusted ventilatory assist, the proportional modes, those are nice for patients that you're describing, because if they don't work that hard, if they work hard, they get more support. And that's probably a better way to protect the diaphragm. But, there's not hard data for those things.
Yeah. Wonderful. Dr. Siuba, thank you so much. I'm hearing that there's some conversation already happening on Twitter. So we're going to go ahead and end now here at 6 o'clock, 7 o'clock your time. And thank you so much again. And for those of you who did not catch the CE slide at the beginning, just please send us an email, communications@sccmse.org, and we can get that to you. And thank you again.
Thanks, everyone.
Bye.